My name is Dr. Kristen Newman, and I am the Maternal Child Health Program Manager at the Prince George's County Health Department. And I have the honor of introducing our moderator for this panel, Dr. Lyneia Richardson, who is a licensed psychologist with over 12 years of experience providing direct therapy services in a variety of clinical and community settings, including substance abuse treatment centers, hospitals, and private practice. Dr. Richardson received her BA in psychology from North Carolina A&T State University, her MS in mental health counseling from Johns Hopkins University, and her PhD in counseling psychology from Howard University in Washington, D.C. She previously worked as a staff psychologist of a university counseling center. She is currently a tenure-track assistant professor at McDaniel College in their counseling program and is the owner of a private practice healing space where she has carved out a special niche focusing on perinatal and women's mental wellness. Please welcome Dr. Lyneia Richardson.
Hello, everyone. Oh, thank you for that introduction. It always sounds so good when someone reads your introduction and you're like, is that me? So I feel very honored and excited about being here with you all today. And in this room, I was just telling someone about the energy, like, oh, we're all doing the work. You know, now we just need the people who aren't, as some have said. So I am going to start by introducing our panelists. So I am a moderator / panelist, but I'll make sure that the panelists have most of the time, because I can tell you now that I am not supposed to really be here. You know, we were talking about all these things about the history of people that look like me. And when I say that, I'm talking about being a Black woman in this world. I'm also talking about being a Black woman who's had 2 children. One experience in which, again, the fear was that I wouldn't be here today to live to even tell the story. And that's actually one of the things that I'm currently doing, is working on talking about our birth stories so that people know what we experience after we have children, so that they can come back to that humanity. You know, when you think about your mom dying, or your sister or your aunt trying to give birth to you, right? The people that are in here in this room. So without further ado, I'm going to introduce the panelists, but I also wanted to talk about our goal for today. So this is a little different than the setup for the other speakers who have had presentations and who have talked more about research. So we're going to be talking about our experiences as mental health professionals working in the perinatal world, as well as talking about some of the challenges and other issues that we see, focusing in on identifying ways that we can improve outcomes for birthing people in Maryland. And we hope that by the end of this discussion, that we all are inspired and equipped to really be able to think about things that we all can do, which is what we've done so far here. So our first panelist is Kristen Brooks. And Kristen Brooks is the founder and lead clinician of Building Beyond Therapy, Inc. With over a decade of experience as a social worker, Kristen has provided social work services in many capacities, including child welfare, inpatient psychiatric services, and schools. Kristen received her MSW from the University of Maryland, Baltimore, and is clinically licensed in Maryland and Washington, D.C. Kristen's true passion lies in helping young women and mothers realize their true importance and potential. Kristen holds a perinatal mental health certificate through Postpartum Support International, or PSI, and has completed specialized trainings in postpartum mood disorders with an emphasis on trauma and pregnancy and infant loss. She's also trained in eye movement desensitization and reprocessing, or EMDR, for those of you who know, therapy. Our next panelist. Okay, next. No. on my form, it's different. But we have Lindsay Standeven, who is an assistant professor of psychiatry at Johns Hopkins and the clinical and education director of Johns Hopkins Reproductive Mental Health Center. After completing her residency in psychiatry, Dr. Standeven completed a 2-year fellowship in reproductive psychiatry. She's the director of resident training in women's mental health and serves on the educational board of the National Curriculum on Reproductive Psychiatry. And her research focuses on the role of neurosteroid changes in pregnancy and PMADs. She has also received NIH funding to study the role of neurosteroids and the psychiatric symptoms of women with polycystic ovary syndrome. And last but not least, we have Amy Radion. Amy Radion is the program coordinator for the Perinatal Depression and Anxiety Outreach Program for the M. Peter Moser Community Initiatives at Sinai Hospital. In this role, she provides psychoeducation support and referral for perinatal mental health. She also runs a virtual weekly postpartum support group. And prior to this position, she was a social worker for the University of Maryland Women's Health Center for 15 years. In this position, she provided the same services for not only perinatal mental health, but also social determinants of health that impact maternal health and well-being. She holds a perinatal mental health certification through Postpartum Support International. She's the informant interviewer for Maryland Maternal Mortality Review Team. And she is also a member of the Baltimore City's Fetal and Infant Mortality Review Program. Let's give a hand for our panelists. That was a mouthful. All right, so now we're actually going to get into the realness of all of this. So with that being said, we've introduced who you are. So can each of you start by sharing why you're working in maternal mental health, right? So why is this important to you and what led you to this work?
Good morning, everybody. So as Dr. Richardson mentioned, I've been a social worker for quite some time, and my initial plan with becoming a social worker was to work with children and families. And that is exactly what I did for a long time. In starting my own family, I was still working with children and families. And it wasn't until my second pregnancy that working with or within maternal mental health was even on my radar. And like a lot of people who are in this work, it is because of my own journey, I guess I'll call it, with maternal mental health, or it being an issue for me. So that second baby knocked me off my feet in all the ways and kickstarted a year-long journey of undiagnosed PMADs. And again, I said I was a social worker, so you would have thought that I would have been like, oh, I know what's going on, and I was completely oblivious. And so because of that experience and that baby, who was the middle of 3, can y'all believe I did it again after that? That's the whole thing. It opened up my eyes to this entire area that I felt like I was completely oblivious to. I didn't know that this was even an area of focus. But it's where I found myself and where I've been ever since, and I absolutely love it.
Thank you.
Hi, everybody. Pleasure to be here. I think I came to this space through, I'd sort of say, 3 pillars. The first is, as a psychiatrist, I'm very interested in mood and anxiety disorders. So sort of what I focused on in training. And then the second thing that really happened for me as I went through my training is that I realized that what I love the most is education as a form of advocacy. And the thing that appalled me was the fact that going through my psychiatry training and then afterwards being a psychiatrist in the field is that there's no dedicated time to women's mental health. It is not a requirement as part of psychiatric training. And so we have designated training, we have fellowships in geriatrics, we have fellowships in child and adolescent psychiatry, but there is no acknowledgement that the biology of women is just different, and it should inform our therapeutic practices, our psychiatric practices, and just our thinking about quality of life, right, as we are lifting and helping other individuals. So I would say that education was sort of the thing that continues to sort of inspire me. And then the third was my own experience. I think many of us come to that. I was actually already in the field and started my own journey with infertility and a NICU baby. And even this morning, my 6-year-old said, "Mom, we should have another. I only have 2."
Yeah, don't do forget.
And I could feel my whole body tense up. Right.
Mine
I could
said
still
that last
feel,
week.
I could still feel that trauma.
Mhm.
And so I think that, would sort of be the 3 pillars that brought me here.
Interesting. Well, my story is very different. I rolled into life wanting to be a computer science major, fell into psych because I was going to fail out of college. And had the opportunity, I really was, it was very bad. Had the opportunity for my senior thesis to interview a woman who had postpartum psychosis. It was one of the most profound things that I got to do. So then I fell into the world of social work. Yeah, go social work. girls. And I think that I grew up with a family that people were people, and we don't have humanity anymore in this world. And I think that that's what really drives me. And I get to work. I am privileged every day to have been a part of the birth stories of so many people who didn't have a voice. And some of the most poignant things I've learned about this is that in my own journey, I'm a IVF too with 3 daughters. Pray for me. Thank you. Please do. And I am 1 in 5. I struggled after the birth of my 3rd child. I lost my mother in my pregnancy, and it was the most difficult postpartum period I had. But the other thing is that as a white woman, I never feared my labor.
Yeah.
And it is so powerful to work with women of color to say, speak up and tell your story. So I feel like it's my responsibility to use my privilege as a white woman to give voices to people who don't have it and how to teach them how to be the voice that they need to be. And your mental health matters. It's just more important than your physical health. Your brain is not separate from your body. Thank you.
Thank you. Yeah. And, you know, I think it's interesting that we all have that shared experience in some way or another, how you got introduced into maternal mental health. So similarly, so you're saying in psychiatry, in psychology, I didn't even know that there was a maternal mental health thing. There was something you could actually specialize in. So we talk about specialties all the time, but there wasn't anything that guided you toward this. And I learned about PSI on my own, and because of my own experience, my daughter was in the NICU, and again, that experience, the trauma, and I have 2, I did it too. I had 1, I was like, oh, how do you get here? Why do people do this? And then you have 3, how did you get here? Why did you do that? You know,
I don't know.
What happened? But clearly, right,
you forget.
there's something, we want to do that. We want to be able to have children freely. And so I think that's a part of this conversation, that we don't want people, I echo, we don't want people to fear giving birth. We don't want people to be afraid. We want them to embrace all of the beauty that comes with it, because apparently people keep going, you know? So
Yeah.
so I'm going to kind of shift it here and start to talk more about what you see, you know, in your work and in your professional experience. So can you talk about what are some of the key disparities or barriers to accessing mental health services or care for birthing people in our state? What do you see?
I mean, well, I can start with access to care from a mental health perspective. There's so few people that are trained in perimental health, and there's so few people that take medical assistance, which is a huge barrier. My belief is it's reimbursement is the issue, which is crazy to me. But I think that from that perspective, again, what are we doing as mental health professionals in our own field with making sure this is being taught to people? But I think from an access of care standpoint, the biggest frustration I run into is finding providers with this training who take medical assistance.
I would completely agree. And I think one of the things, so it's access to care. Okay, so let's break that down, right? So even if we screened, then we need to find individuals who can care for the patients. That means we need to find individuals for the patients who take their insurance, which I think we've been talking about institutional injustice, institutional racism. Okay, this is just inequitable care, right? The fact that Medicaid doesn't reimburse the same, the fact that we have different insurances, it is inequitable care. And so, you know, and so this is our issue with doulas. This is our issue with psychiatrists. This is our issues with social workers, is we're all here trying to stay above water, and including our patients that we're trying to take care of. And so we end up begging, right? We end up begging for grants. We end up begging for money. We celebrate the money that we get to have for a short period of time to be able to put a Band-Aid on this hemorrhage. And I think the other part that I'm very passionate about, right, is so then even if we found the therapist, even if we found the doctors, they don't have the training, right? And what do I mean by training? Well, we could break that down into, they don't have the training in how to prescribe in pregnancy. They don't have the training in how to diagnose or understand what these illnesses look like. they don't understand, they don't have the training to think about the context in which they occur in, right? And think of it through a, societal lens. I mean, the problem is, there's a part in medical school where we have to actually take classes on, it's basically classes on humanity, where I don't know if there are MDs in the room or DOs, but you actually have to go through, like, how do you have empathy for your patients? I know you're a doctor. Correct, doctoring. And I always just sat there and I was like, is this something we can teach? Because I think what it comes down to, right? And I think what brings many of us to this field and to wanting to care for people in general is that when you look into the eyes of someone who comes from a completely different path from you, and yet you have this unbelievable shared experience, that's why that makes you feel human and connected. And I don't know how to teach that, and I don't know how to get government to care about that. That's all I'm going to say about that.
So it's an interesting thing. So like I said, I started out in child welfare, right? That was not because I actually wanted to work in child welfare. Let's be very clear. I did not want to work in child protective services. I did not want to work for the Department of Social Services. But why do you think that that was my area of focus when I went into school? Because they gave money.
Yep.
Right? I went to the University of Maryland in Baltimore, lovely place. But when I came in, it was like, oh, we have this program called the Title IV program, where you come in, right, and we'll give you money. And I'm like, oh, I need that because I'm a broke college student.
Yep.
And on top of us giving you money, because we've given you money for this 2 years, you then commit to working in the workforce for 2 years. And I was like, oh, I get money in school and a guaranteed job. Check, check. I'll be there. And I showed up, right? So I tell people, like, I was taught and trained to be a child welfare robot. I had 2 years of commitment. Guess how long I worked for the Department of Social Services?
30 days.
2 years. I wasn't paying that money back. Didn't you just hear me say I was broken? I was not paying that money back. I started on June 12th, 2012. I left on June 12th, 2014. I did my commitment, right? And then after that, I was like, okay, now what? The school has a maternal child health program, or at the time had a maternal child health specialty. I never even looked into any of the other specialties because they weren't giving me money. So if we're talking about people not being trained, right? We're talking about there being this gap in knowledge. There was a gap in knowledge in my social work school. I guarantee you, if we started incentivizing some of these programs, we'd get people in the workforce because people need money to go to school. We need guaranteed jobs when we get out of school. And so that's one of the conversations I've been having with people, with Tanae and Dr. Neal at the Maternal Health Improvement Task Force for the state. It's like, how do we build the workforce? We got to give people money. We got that. I mean, just like with kids, I don't know about you. I brought my kids to do everything. That's how they got potty trained. You go to the bathroom, you get a piece of candy, right? We have to incentivize people to come into this work when we know that there's a need. We see that there's a need. And then you talk about training. This perinatal mental health certification that we have is not cheap.
Nope.
It was not cheap, right? We have to pay for a foundational training, an advanced training, an exam that's $500. That's not all together. The exam was $500. The trainings themselves are $400, $300. And so, it's a blessing and a privilege to be able to afford that out of pocket, but not everybody can do that. So we need to figure out ways to incentivize and provide money to people if we really want to build the workforce to be able to support the clients that we have.
And a workforce that looks like the clients that we have.
That part.
Yes, and I think this actually goes into the next question, and I experienced this too. So the question is about challenges that you run into as a provider, right? So we're talking about what happens for the people who are trying to access the care. But I would say the same thing. I need a job too. I have 2 kids, and we talk about, as others have said, this idea of it's almost this dichotomy, right? There's Medicaid, so there's we need providers to take Medicaid, and then there's non-Medicaid, and that's it. That's the split. And if I don't take Medicaid, then I'm not going to be able to work in any of those spaces that accept Medicaid. So you have this piece of, like, as a provider, yes, I want to give back to the community. Yes, I do give back to the community. I actually volunteer my time. But I also want to get paid to be able to do the work and to be able to do the work well, because I'm not burnt out or leaving a job on the 2-year mark.
Baby,
And so I think that's part of it too. And you know, this is a problem across the board as therapists, but I think about ways that, you know, the doctors, how can they refer clients directly to us? But if I don't take Medicare, then or Medicaid, I'm not that therapist, right, that the client can see. So what about the people who aren't on Medicaid? And I think that that's the conversation that's lost, is that there are people receiving care. There are a lot of people receiving care, but clients that come to me don't have Medicaid and sometimes don't want to use their insurance, but how can they find me? So that's one of the questions too. And I don't know if you all have experiences like that where you can think about or talk about what challenges you've run into, or even your colleagues, because I have this conversation often.
So in private practice, my private practice has always accepted insurance. And so when it started out as just me, I was really intentional, and it meant a lot to me to be able to take insurance because I wanted to see people like me, right? If I'm going to seek services, I want to use the insurance that my husband pays for. So I want people to be able to utilize their insurance. And while that makes me feel really warm and fuzzy on the inside, every single time that I have to sit on the phone for hours to chase claims or to verify insurance benefits or to be able to tell that person like, yeah, I'm in your network, but your deductible is $9,500. So you have to pay out of pocket anyway, right? So I will sit on the phone and the mantra is, I will continue to take insurance. I will continue to take insurance because Dr. Richardson is correct. While I do take Medicaid, I also take Cigna, Blue Cross, United Healthcare, and Aetna, and that is the basis of my practice. Medicaid at first was who floated me, and thank y'all for that. I appreciate it. But there is a large majority of the people in our practice who have private insurance, and they are still having difficulty finding people. And people will still come to me and say, hey, do you have any openings? Because I want to or need to be able to use my insurance. And there are not enough providers that accept insurance. On top of, which I'm sure all of you are familiar with at this point, this recent Change Healthcare breach. There are providers who are not being paid, have not been paid since February. There are providers who have decided to stop seeing certain patients because they are not being paid. Their staff are not being paid. So now they are resorting to, well, we can't see you. You're going to have to pay out of pocket. Who can afford that? I can't. And I work in the system. I have a therapist that does not accept insurance and I pay her out of pocket. And while I love her, I'm also like, oh girl, okay, we're not going to see each other every week. Let's go to once a month. Right? Thankfully, I don't need you more than that. But if I did, I'd be in a pickle. Right? I'd have a huge issue on my hands if there was support that I needed. And so I think that there's this like, yes, reimbursement is an issue. What I do for myself is I'll tell myself like, Kristen, you would not have made this much money an hour working at DSS. And that's how I bring myself back down. Like I humble myself in a moment, but that's only going to last for so long. I have a family who's growing and they eat and I have to pay for them and my mortgage and gas is not cheap and groceries are not cheap. And so the things are growing. Student loans, don't even get me started there. Right? So like we do, yes, we are helping professionals, but we also have families and lives to maintain and we can't do that. It's like this gap between do I do that and provide care, but then my family suffers, or do I not, and then my community suffers.
And I think that I totally agree. And I think, you know, what it comes down to when we're thinking about mental health reimbursement, right, is a country that doesn't care about this. And just to sort of say it frankly, and also doesn't care about the people who continue to suffer with it and are disproportionately affected by it. And so, I mean, so out of, you know, in the academic world or in other spaces, you know, if I'm spending a portion of my time seeing individuals who are publicly insured, you know, that pays for a minutia of my salary, right? And so then I'm then spread into 7 different directions. And so then I'm not giving good care to probably myself, my patients, or my family. And that just leads to this perpetuation of what we were talking about before, right? Where we have doctors who are seeing these patients for 10 minutes. And what are they supposed to do in 10 minutes? It's a huge amount. And it just perpetuates the cycle of us not giving the basic care, the basic rights that individuals should have. So I think the biggest part here also is that it's thinking about how we can not only increase access to care, but I do want to talk about silos at some point, but we'll get back to that. But also, how can we ensure that there are all hands on deck, right? That it's not that it shouldn't be that they wait into the postpartum to get into mental health care, right? When we think about preventative care, when we think about what does it mean for a individual to flourish over their lifespan, right? You came from the child world, and that's because it all starts there, right? It all starts on the dyadic care in childhood, and how are we building individuals' lives from the start and respecting them as humans, which includes access to equitable healthcare.
And I think that's actually a good segue into the next question, which is asking, are there specific groups or stakeholders that could come together to improve access to care, right? Or enhance the overall care or experience for these pregnant people?
I don't know where the question, I think it was you, ma'am, in the blue. You look lovely, by the way. But you asked the question, like, how do we fight the fear that people have, right? And so Tanae talked about this holistic approach. While I am a perinatal mental health therapist, I'm a social worker first. And one of the things that we are taught in social work school is to look at the whole, right? We're looking at everybody. We're looking at the whole system. We sit down, we make our little eco maps with all the little bubbles and the lines. And I didn't realize other professions didn't do that. So I was like, oh, y'all don't know this? Let me teach you something. So
Everybody should be a
from the beginning of our work with people, we have to start asking the questions. Who do you already have?
Yep.
Do you even know that you might need someone in this way? I was a social worker who has had 3 children. I love my providers, but I don't ever remember any of them asking me, do you have a therapist? Do you have a chiropractor? Do you have a whatever, fill in the blank? And again, it wasn't until it was, I won't say too late, but we were being more reactive in that moment than being proactive. And I think that bringing everybody to the table, if you are an OB or a midwife or a doula and you are seeing a pregnant person, ask them, do you have mental health support? Because even if they don't think they need it yet, even if there is not an actual PMADS yet, they could still benefit from coming to talk to someone and be like, girl, this is hard. And you'd be like, I know.
Yep.
It is, but it's all right. It will be all right. Right. And in that case, let somebody else be present to catch it when it happens, because you won't be there anymore. So I think just starting from the beginning and asking questions about who people have in their circle, in their system, is going to make it a lot easier for us to all work together and then actually reach out to those people. Like, we have phones and emails and fax numbers that work. Like, reach out, talk to us. Like Tanae said, build that relationship and community. This lovely lady right here, Dr. Kristen Newman, is the only reason that I'm sitting up here, because one person, a mutual connection between us, connected us years ago. And now every single time something comes up, she's like, oh, I already said you would do it. And I was like, oh. In her program, she will get a pregnant person, and she just asked me right now, you have somebody who can take this client? I'm like, we can. So that costs us nothing.
Yep.
It has built a beautiful partnership and a beautiful relationship that allows us to benefit and to serve the people in our community.
Well, I think the other thing is building on the community relationships, right? Like, it takes anywhere from 8 to 12 weeks to get somebody into therapy right now. But if you've got a doula who's trained in mental health, which they are, if you've got community health workers that have some just semblance of mental health training, I'm not asking you to be the therapist, but to be the support.
Right.
We in this state have home visiting programs, right? Learned about some of them yesterday in the Ignite session, right? How much training are they getting to be that bridge until we can get somebody into, because not everybody's going to have clinical depression and clinical anxiety, right?
People need
And a lot of people, if we can get them early, it's not going to get there, right? So I think that utilizing the workforce that we have, and all community health workers, I don't care what you're going in, it should be a part of the community health workers training to learn about maternal mental health, because I don't care what you do. Let's say you work in diabetes, right? And your client is struggling and was doing great, but all of a sudden his daughter's not really helping anymore. And then you find out from him, oh, baby girl just had a baby. Bam. If I'm a community health worker who's been trained on maternal mental health, my first thought is, I got to help his daughter so I can continue to help him in his journey. Everybody in this room knows that women run the world. Let's just stop right there. Okay. And until we start prioritizing women, I got 3 daughters, right? Until we start recognizing that, we have to change. And I don't care who you are. We need to change the way we train medical students, right? Completely need to train it, right? There's so much we need to do differently. So if you're in this room and you do education, what do they do about this? Right?
Mhm.
And I don't care who you are, or what you do, if you're an administrator or who you are a piece of this puzzle that can
Mhm.
fix it, but we need to utilize what we have in front of us.
Thank you. Yeah, I was like, that's a pause for me. So I think we already are kind of talking about the next question around how we think that collaboration between these groups can actually improve the outcomes, right? So this next question is actually leaning more towards, do you have ideas about some strategies, or maybe there's some protocols that can be implemented that would really help to facilitate the transition? So we know and recognize after after the person is giving birth and they are going back into their community, how do we facilitate that transition to mental health providers? So how can they get to us?
Well, let's not put it in that 80-page discharge summary.
Thank you. Thank you very much.
Please, please. They don't find it.
Nope.
They're not looking at it. They'll never see it. They will never get to me. I think it's hard sometimes, like, again, it is contingent upon us having these relationships with people, right? It is not enough for you to give somebody a list and say like, oh, call these providers, because they're only gonna call maybe two.
Yep.
And the minute we don't answer, because we don't answer the phone, because we're working, right? The minute we don't answer and they don't leave a message, or they do leave a message, and unfortunately providers don't call back, they won't call anybody back. So I know it may be unrealistic for you to be able to do a warm handoff, but if you can do it, if you have someone in your office that can do it, because it's going to make a difference. If someone, when Dr. Newman calls me, because she doesn't call the business line, she doesn't even email me, she calls Kristen's personal cell phone and be like, hey girl, on her way home from work. And I'm like, what you need? She will call me and say, this is this person's information. I have a totally different process for her people than I do for anyone who's coming from somewhere else, because we have that relationship. So I think that it's a matter of like, don't put it in the discharge paperwork just because you can say you check the box. Have a like fluorescent flyer or something that just has that information on it, big bold letters. If you feel this way, if you feel that way, if you don't feel like yourself, call this number. Change it up, switch it up, be creative, use colors and shapes and bright lights, whatever it is. Actually have the conversation, not with the person who just gave birth because they don't hear you. Maybe whomever the support person is that's with them. Let's loop these people in that are in their systems and connections. No one ever told my husband, hey, here's some information for her. I don't even think they talked to him. He was there the whole time for all three. My mama, his mama, him, me. No one ever talked to them. Don't talk to I didn't hear them. I've been pushing that baby out. I got cut for that one. And she just went to the NICU. Please don't talk to me. Talk to the people around who might hear you a little bit better. Have the conversation several times. At the beginning, in the middle, at the end, after they leave, when they come back to your office. Have the conversation over and over, because just to say you did it once to check a box isn't enough.
And I agree with you with the support person. So when I would meet with patients, if somebody was in the room, I would look at the support person and go, you can rat her out. Here's my number. And I said it in front of the patient. I would say, you can call me anytime and rat her out to me. My husband did it to me. So that's why I say that to people. But I think that there's just so many things I can say about this. But the key to this is we have to change the way we do obstetric care. Centering pregnancy is the most absolute fantastic thing on the face of the earth. And I think everybody, no matter if you're high risk, low risk, whoever you are, should be in centering. One of the most poignant conversations I had is we did centering diabetes care before the pandemic at university, sat in a room with 3 women of color who were scared to death that they were going to die when they delivered their child, right? They supported each other. We provided them with support. We gave them ways to advocate for themselves. So this is how things change, is community. We've said it, it's been said 1,000 times, right? But I think that we have to change the way that we do prenatal care and postnatal care. Because you take care of me for 9-10 months, depending upon when I rolled into your office, and then 6 weeks later you say deuces.
You drop me.
You drive me like a
sack of potatoes.
Exactly.
And I think that's also the part where we have to think about silos, right? So
Yeah.
when we were looking at the graphs earlier, right, the majority of suicides and unintentional overdoses happen at the end of the year. Okay, it's not in the first 6 months, and the postpartum visit is at 6 weeks. Okay. And then, so from a postpartum psychosis perspective, which is one of my passions, they don't even see them. It's too late at that point. And if we're talking about the fact that the majority of the deaths are actually occurring later in the year, OBs are done. That's not their patient anymore. Okay. So part of this is thinking about how you are a doctor, right? How you are a provider, how you are caring for individuals, and taking away some of the preconceptions about being in a silo. So one of my favorite things is if I get the chance to talk to my fellow psychiatrists about prescribing birth control, right? Or having conversations early on before the individual gets pregnant about choice. Okay. So here we are, we're managing these very serious symptoms you're having. I want to be thoughtful about what medicines you're on, and if this is a good time for you to get pregnant, and what your timeline is and what your desires are and how I can benefit that, right? So giving them the training to do that, that's the psychiatrist. And then for the same part, how can we get our OBs to say, yes, I will prescribe for this patient through the first year postpartum. They're still my patient. Even though I'm an OB, now I'm crossing into GYN territory. I'm looking at you, right? There's this divide. And the same thing with our pediatricians. Again, though, they have 15 minutes, right? And so it goes back to time, billing, and the system of emphasis, and also the medical education, right? And also the therapeutic education in terms of I'm an expert in this, but not in this.
Right.
Even though it's all overlapping.
And I was going to say that part about the interconnectedness of it all. And I think the challenge is that when you're pregnant, you're an incubator. You're really, really important for the health of the child. And then once the baby gets here, the mom is ultimately forgotten. And I think when we talk about this mental health piece, that's the part of the mental health challenge after giving birth, is that I've done this almost 10 months of work incubating, making sure that I bring this child to health. And then when the baby gets here, that's all everyone wants to think about. That's all anyone ever asks about. And that's all anyone cares about. And I'm supposed to be happy. So when I'm sad or when I'm feeling like, I just want this baby to stop crying, who can I tell that to? And who's talked to me about it? So I thought your comment was interesting, Kristen, because the same thing happened to me. I had a C-section, 2 C-sections. But for the second one, my husband told me this whole elaborate story about how my son was in the room with me for like an hour, and my sister was there, and she was holding the baby, and I was like, I do not remember any of that. He was like, the nurse was telling you that. Like, I don't remember anything, right? So for me, that piece of like recognizing that there's some challenges with understanding how the information is being provided. So we've been talking about, I think, education in this section, like how is the information getting to the woman or the mother, the birthing person, and the person who's going to be caring for the child. So I think that's part of it too. We're talking about our system of care. I mean, we could go into other policies like leave, going back to work after 6 weeks or 8 weeks.
Can I comment on
so
one
many
other
layers.
thing? The other thing, right, is that we focus on women's health is mostly about being a vessel. It's about the reproductive time, right? And I loved the idea when we were talking about, what on earth is happening in health classes. I have 2 boys, a 6 and a 2-year-old, so I'm not there yet. But, the fact that we need to start thinking about how individuals view their body and their control over their body, and having conversations about that, not even just related to reproduction, just being a female, being a woman in the world, right? And starting those conversations about reproductive rights and freedom very early by understanding our bodies and advocacy, and into perimenopause and menopause. Because then once you stop being a vessel, then nobody is talking to you about what you're going through.
Right. And we're talking about the mind-body connection too. Yeah.
You're done.
Yeah. Well,
But I also think that
uh-huh.
both sides of this fence need to know, right? I have 3 daughters and a stepson. My stepson needs to know just as much about women's health as do my daughters need to know about male health, right? Like, and I think that we can't be I watched a video about Captain Condom. That was what we learned when I was in school, right? Nothing about period, none of this stuff, right? None of these things, right? So it was horrible. It was the 90s. It was the 90s, ladies and gentlemen, it was the 90s. But I think that that's where we've missed this boat, right? We should not be two separate entities, right? Because, and I think, you know, we could come up with the dudas instead of the doulas for the dads, right? Like, I love that question, the dudas, right?
I love it.
Do you know what I mean?
Yeah.
Oh, sweet. But I think that that's where we just have to like stop the silos. Like you keep using that, is that everybody needs to know about each other.
Mhm.
It's really important that we know about each other.
Yeah, and I was saying that there's a mind-body connection, right?
Yep.
We kind of forget that. So we shouldn't be separate. We should all be talking together because there's that holistic care that we were talking about.
And reimbursed at the same rate.
Amen. Well, there was a Time article that just came out that like you get $1,000 for prenatal care, but $1,600 for a 1-hour knee surgery. Give me a break. I'm just saying.
So we could go on about the money thing.
We
'cause,
sure
you know,
could.
I have some gripes, but what I do want to do is go into, so as we've said in these other presentations, what can we do? Because that's really what we're here for, right? So can you all or any of you highlight some initiatives or maybe some models of care that have shown promise in actually reducing disparities or improving maternal mental health?
So I'm a very big proponent of collaborative care. And the idea is that basically very few people need to see a reproductive psychiatrist, like, right? I mean, so individuals, I would say 20% of individuals who screen positive need to be seen by me. And instead, the idea here is that we can have all different individuals interfacing with patients. And it's an all hands on deck approach, right? So in collaborative care, if you don't know about it, there is a case manager or a social worker who then works with the obstetrician. So the obstetrician or the pediatrician or the primary care doctor screens their patients for mental health conditions. And then if somebody screens positive, they're entered into a database and then they're given additional care services. Most of the time it's therapy, but I think there should be other services that are involved. And what it's basically been found to do is to reduce in the primary care world, it reduces comorbidity, it increases adherence, and it reduces mortality and morbidity. And we're just now studying it in the OBGYN world.
Mhm.
And what I think is fascinating about this and is important about it is it removes the bottleneck. Right. So for all of the patients that are referred to me, I probably only need to see about 1 out of 10 of them. Like, right. The patients that I need to see are the ones that the OBs are really not comfortable and probably shouldn't be caring for because, you know, I'm not going to go deliver a baby. They probably shouldn't be managing postpartum psychosis and bipolar and pregnancy. But I can prescribe birth control and they can screen for depression and anxiety and treat it.
Mhm.
And so the idea is that if we can implement standardized screening, and then we can have psychiatric providers provide recommendations and education to the OBs so they feel empowered to deliver the care, then they've removed the bottleneck for me. And these patients are getting earlier access and care so that we're not then chasing upstream on the other side when they're postpartum, right? So we're identifying them early, we're intervening early. So at Johns Hopkins, we had an integrated care clinic that I've been desperately trying to move to collaborative care for years. But what we've found from just the integrated care clinics is that our presence there improved mental health outcomes. That's good, we did our job. But it also reduced the risk of emergency C-sections and it reduced the number of emergency room calls and calls to labor and delivery, right? So the idea here is what we know is that Black women in this country are screened less for perinatal mental health conditions. They show up to their care less. It's half at each time, each increment, okay? And then by the time that they're screened and treated, only 5% are treated into remission. There's literally no other condition that we do such a bad job with, and we're like, that's okay. All right. We don't say that with diabetes or asthma.
No, sure don't.
But we do in this area. And so again, the idea is sort of all hands on deck. Let's take it out of the silo. Let's have the conversations. And Maryland has passed collaborative care codes. So again, going back to do I have to stop begging and can we actually say I can have a job doing this? We have.
Well, I mean, and I think that I personally think that every obstetrician office should have a social worker embedded in it. And that social worker should be able to be reimbursed for all of the work that we do.
Please.
Because we are not only addressing mental health, we are also addressing social determinants of health. So I think that ideally you have a mental health social worker, and then you would have the social worker that could help, or that's where you put in community health workers, right? But you have to have the people in the place, because you are correct. The OB gets 10 to 15 minutes with the patient, right? But again, if we had more reimbursement, that they could now spend 30 minutes with a patient, because we know that the patients want to hear it from the OB provider. And the problem is there are OB providers in this world that are so focused on perinatal mental health, but they get burnt out because they don't have the support that they need to make it happen, right? And I think that it's putting the people in the places that work. And I think, like, you know, large academic institutions, they have social workers, right? But these private practices, they're going to have to somewhere in their budget find a way to do that. And that's not sometimes feasible, right? But I would highly recommend that somebody might want to look at doing this. But I just think it's having the people who are passionate about it, because to go back to what you said, Kristen, I think that, and Lindsay, you said it too, is that you have to have a passion for this, right? And clearly everybody in this room does, because you took the time out of your day to be here today, and the people who are online, hey, how you doing? Are also passionate about this. But, you know, where are the money people? So I'm going to say.
Great. So how can healthcare providers and policymakers effectively connect with local communities to help raise awareness about the maternal mental health, issues, and maybe community partnerships be leveraged? Any ideas?
Listen to the people. Go to the Bloom, ask to speak to their clients, go to Be More for Healthy Babies. There are so many, listen to the people we are caring for. Come at it. I'm going to get real not nice here, probably. Come out of your office, come out of your big tower, come down and hear what somebody has to say. There is nothing like the power of storytelling, right? If you cannot sit in a room and listen to women's experiences of what they have gone through, and if you are not moved, you need to get out of this business and go do something else.
I think being intentional about coming into space and like removing what you think you know and who you think you know is really important. I have found some wonderful, or been told about some wonderful resources from my clients. And they'll be like, oh, I ask all the questions. I'm like, who's your doctor? Who's your doula? You got a dentist? Who's the dentist? I'm asking who everybody is, because I am compiling a list in my brain of people that, one, I am absolutely checking you out. So if I get 2 bad reviews, you don't ever have to worry about me sending somebody to you.
Exactly.
Let's be very clear. And I will tell you, oh, I heard things about you. I don't send people to you because you need to know, because they may not be comfortable telling you, but I am. So 1, asking the questions, gathering the resources, but 2, like they said, come talk to us. I promise we won't bite you. We are probably looking for you. I've been trying to reach somebody at the hospital, the birthing hospital that is within walking distance of my office for years, since their director of women's services left. I still don't know who's in that role. There's not a phone number directly to anybody on the website. There's not an email address. And I don't even know if I can just walk in the hospital. Can you just walk in hospitals now after COVID? Right. I'm gonna get stopped at the door. So I don't know. Right. But it's like
pregnant person.
Huh?
You need a pregnant person.
Yeah, but pregnant people don't want to birth at that hospital.
Oh, that's a problem. Then.
That's the problem, right? I'm trying to get in there so I can help y'all make y'all money and restore your business, because the people in your community don't trust you.
That's right.
I worked at not that hospital, but a different birthing hospital. I worked there while pregnant with that second baby. And I kept telling people in the unit, if I go into labor, if y'all take me downstairs to labor and delivery, I'm gonna come back and haunt you. Because I would not birth in this hospital. That is my technical birthing hospital because it's closest to my house if you paid me. But it is like fighting. We are pulling teeth to try to connect with anyone and find a number. I have emailed people in my community, counsel people in my community. I have gotten no response. So now I show up at events and I accost you. Hey, how you doing? But it's just me. I got things to do. I told you I got these 3 kids. They got activities. I can't be at everything in the county. PG County is very large, right? So just, Google search MD Mom created this beautiful interactive map. If you've never seen it on the website, there's lots of things. Start just cold calling us, because we've been trying to call y'all. So start, reverse it. Call us, court us for a change.
There you go.
That's actually one thing that I mean, there have been efforts to continue to update like a resource list, right?
Mhm.
But Sarah and I talk about this all the time. But that's a job.
It
That's
is.
3 or 4 jobs is
Mhm.
having a resource list that's updated because we're moving constantly,
Yep.
right? And where the resources are going and who's
Mhm.
taking what insurance and where everybody.
You need money. You need to hire someone that
Right.
would be able to do, right? Because it's time consuming and
Mhm.
people have
Right.
children, and they don't have time. So
Right.
they're your mother and you're trying to do the work.
But like, I mean, that's what you're doing, right? Is you're creating your own community
Right.
for individuals. You're creating your own booklet of
Mhm.
these are our people
Yep.
who I believe these are who I would want my mother and my sister to see,
Or
Mhm.
me.
right? Or you,
Yeah.
yeah.
Yes. And I wanted to go back to something you said, Kristen, and I think this is the part of like us, the people in the room that are doing the work, that sometimes I think we, and I'm gonna say collective we lose our humility in thinking that we
Mhm.
know, right? And I think you said, like, if we just enter into spaces with, I tell my students this all the time. I'm training up the next group of mental health professionals, help me. So I tell them all the time, right? I know nothing.
Mhm.
I enter into a space and I know nothing. I do have a degree, but I know nothing. And I keep that here because it allows me to not think that I know more than the person that's standing in front of me.
Yep.
I never want a client to
Yeah.
feel like I'm telling them how they should feel or what they're feeling. And I've been in that position as the patient who was on the operating table, and I could feel. I don't think you're supposed to feel any doctors in here when you're having a C-section. I think you're supposed to be numb, from what I understand.
Yes, you
And
are.
I could feel
Yes.
something, and I expressed that I could feel something, and I thought you're not supposed to feel anything. And it was so interesting because the doctor, the person who was operating on me, had to tell the anesthesiologist, like, you need to figure this out. But I'm telling you, I can feel it. So it's so interesting to think about how this is what is happening. Our birthing people are saying, hear me, listen.
Yep.
And when we go in saying that we know more than they do, or we know more about this or mental health or whatever that is, then, I think that's the piece where we say, like, educate, tell them to advocate for themselves. But if you've been advocating for yourself, if you've been telling your doctor, you have Medicaid, I can't just switch my doctor or choose my
Right.
therapist. I have to do whatever the system says. Then how can they advocate in this system that isn't even listening to them? So I think that the onus is on us too, and the people who are in the spaces for those folks. And so as we're kind of coming to an end, and I think maybe this might give some time for you all in the audience, online, to reflect a little bit. Do you all have any kind of last words, steps, actionable steps, things that we can take away after this discussion to really help the experience of the birthing people in our state?
I think everybody in this room is probably on the same page, but I think that we need to look at the birthing person as the expert in them. Yes, they have come to you for OB care. Yes, they've come to me for mental health support. And I have my training, I have my expertise in what I do, but I'm not the expert in the person sitting in front of me. And this doesn't have to be a power struggle, right? We need to bring our expertise to the table to figure out how we do this. And I think that that's where we forget that the person we are working with is the expert in them, the way that they describe their pain, the way that they talk about their moods and emotions, the way that they talk about things. They may use different verbiage than we do. That's not the medical definition, right? Who's got sugar, right? If you didn't know that meant diabetes, then you're going to really be confused by the conversation that you are having with somebody, right? So I think that is, to me, every person I have interact with, they are the expert in them. I have my expertise, what I know, but I need to know what they need, right? The core of social work, start where the patient is.
That's such a social worky thing.
It's so,
It
I'm
is.
telling you, we rule the
I
world.
know we.
But anyways,
do.
but it is,
We
it's
do.
the one thing that I tell everybody. I think that, maybe doctors in general in medical school, you need to have a class on what it means to be a social worker, or what would the social worker do?
Bring us in to teach it.
Exactly.
Yeah, we could
Start
do
where the person
We could do it.
that's what I would say. They're the expert in them. And yes, we have our expertise, but we have to respect their expertise and knowing themselves.
I agree. Because again, like I remember when I worked in child welfare, like we of course would get the file, right? I had the file on the report that was made, and I can't tell you how many times I'll go to somebody's house and I'm like, okay, tell me what's going on. They'd be like, but you have your file right there. And I said, but I didn't read it. Because that doesn't tell me all the parts. Like, I don't wanna, like, yes, I have to read some of the important things, right? So please also check people's charts before you go and asking questions, especially like the important stuff. Like previous losses, what's going on in this pregnancy, like ask the questions, check the things. But then just let people speak, because like Tanae said, if you start building relationships, they're going to tell you the things. They won't withhold it from you if they trust you. So really be cognizant of like, am I trustworthy? Not do I think I'm trustworthy, but the way that people are interacting with me, does that give off the impression that they trust me? And if it doesn't, if you don't know how to fix it, ask somebody else. Ask for the feedback. Tangibly, I would like for you to all go into your communities and 3 to 5 providers that don't do what you do that can support birthing people. If it's a therapist, if it's a chiropractor, I have a wonderful relationship with chiropractors. They'll refer you people all the time, right? Dentists. People are always looking for dentist show. It may seem irrelevant, but it's not. Doulas, lactation consultants. Don't just look at like the larger, like the health department has this program, that's great. But let's think about the things that people don't see, the things that seem to be flying under the radar. So find those hidden gems in your community.
All right, well, thank you. I don't think I left that much time for questions or anything, but.
Y'all nailed everything.
Okay.
Thank you.